Hi, my name is Jim Leffler. I'm a psychiatrist at the Durham VA. Though my comments are mine alone and don't represent the opinions of the Department of Veteran Affairs, nor any of the other entities for which I'm affiliated. Today I want to talk about post-traumatic stress disorder, PTSD. So I'd like to start by talking about the historical roots of post-traumatic stress disorder. And Dr. Warren Kinghorn is a theologian and psychiatrist at the Duke Divinity School and works at the Durham VA. So he's a colleague of mine. And he wrote this article in the Harvard Review of Psychiatry in 2005 about moral injury and the role of psychiatry to engage kind of the whole person. And I encourage anybody that's interested to take a look at that. And I might have just said 2005, I meant 2015. In that article, he describes what was originally talked about as the post-Vietnam syndrome. And the post-Vietnam syndrome eventually became known as PTSD as it underwent quite a significant metamorphosis in DSM-4 and then 5, and then now we think about symptom-based approach to the illness, which I'll talk about just now. However, in its initial conceptualization, there were a lot more kind of moral words or kind of ideas of guilt and shame and doing things that one didn't expect to do or being exposed to something that one did not expect to encounter. And it was more related to kind of the inner life of the human and relating to the human as a human. The idea was then incorporated into the DSM-4 and later on 5 into a symptom-based kind of idea. So what are the symptom-based ideas of PTSD? We have 5, and you'll hear people talk about criterion A. And criterion A is the exposure. Exposure is to an event that is life-threatening, that happened to yourself or that you heard about, happen to someone close to you, or may involve kind of first responders coming upon that happened to someone else and can be that kind of repetitive fashion. But a key component of criterion A is that it does have to be life-threatening. Then you go on and you have to have 4 other core symptoms. And that's criterion B, C, D, and E. And then as always, this can't be attributed to substances or some other medical issue. So criterion B are intrusive symptoms. Criterion C is avoidance. Criterion D, negative cognitions. And criterion E, some kind of reactivity. I'm going to go into a little bit more detail on these. So in the intrusive symptoms, you may think about these as kind of memories of the events, dreams about the events, and often those dreams get called nightmares, or dissociative reactions related to the event or environmental cues that remind one of the event. And what do people avoid? They avoid memories of the event. So if they think about it, they quickly change the conversation, or some type of what's called trigger. So something that causes a person to remember the event in which they are exposed. And they may avoid crowds, or going to a mall is a common thing that I'll experience, or driving on the highway. In the mall around here is that it's crowded and it looks kind of like an outdoor setting, which may be similar to the urban warfare environments of our current veterans, as well as kind of driving on the highway, given the high number of IEDs and kind of explosive events that folks encounter. Negative cognitions. These things are kind of a negative emotional state, which can look a lot like depression. A negative emotional state, decreased interest in activities, and detachment from the world. And one of the best ways, I heard somebody talk about this to me one time, is that they said, I exist in a world and it's as if I'm watching it through my phone and I'm taking a movie of everything that's going on. Like it's out there, I see it, but it's kind of detached as if through a phone. Reactivity or hypervigilance, that can manifest in many ways. We often ask about when you're in a restaurant, do you feel like you need to sit so you can see the exits and the entryways? Or do you have to go around your house and perform kind of ritual behaviors to kind of secure the perimeter, such as locking the doors and making sure no one's there? And not just one time, but multiple times. They have an increased startle response, kind of just increased hyperreactivity, and then their sleep is disrupted and they kind of startle out of sleep. Now the key is that it's got to be greater than 1 month to be PTSD. If it's less than 1 month, we call that acute stress reaction. And if it's greater than 6 months, then it gets the moniker chronic. So those are the exact criteria for the disorder. Now, how do you treat it? So two big treatments, pharmacology and psychological treatment. And I'll come over to that one in just a second. And the big thing you got to know about the pharmacologic treatment is it's not tough. It's SSRIs and SNRIs and the typical dosing strategies that one might use for anxiety disorders or stress or depressive disorders. Now, this is a bit more uncertain now, particularly given the recent paper in New England Journal of Medicine in 2018. Now, the author, if you read that paper in terms of the prazosin study, which was done in veterans, it was a negative study. So the author gives explanations as to why they think that might not have been the case. So I'll leave you guys to read that and read the earlier papers, which I think are worth reading, from the same primary author. I think it's Raskind. I might be mispronouncing that, but 2018 New England Journal of Medicine, prazosin, will find that paper, and then that author's done most of the work in this area. And you can read their conclusions as to why they think it was a negative trial. But you use prazosin, and usually the main side effects of prazosin, as you all know, is an alpha blocking agent. And so if you block alpha, you're going to have decreased blood pressure, particularly on standing, but you're shooting kind of for higher doses of that. And that prazosin is specific for the nightmares, so the dreams that are of the exposure. Or you can add a second generation antipsychotic with Seroquel or quetiapine, which is the generic name for Seroquel, which is brand, which did have a positive monotherapy trial, and the doses was on the order of like 250 and thereabouts. That was the median kind of dose. But I'll leave you guys also to look at that study if you're interested. And those are the main pharmacologic treatments for the illness. Now the psychological treatments. So you have evidence-based treatment. That's what EBT stands for. So you've maybe heard people talk about that. And they're usually trauma-focused, the EBT treatments, meaning that you talk about and look to the trauma as being important. And the two main ones that I know about, and there's others, are CPT, or cognitive processing therapy, and PE, or prolonged therapy. And then you have non-trauma focused therapies, and there are many of those. And one recent study was on something called Montram, I think was the word they used, instead of a mantra, but a Montram, and it was like a mantra, and you learn a mindfulness-based technique to decrease reactivity. and decrease symptoms, and it was a positive study, and that was within the last year, if I remember correctly. So what are the two that I mentioned that I have exposure to? So cognitive processing therapy is a therapy that has folks kind of, you can either do it with this or without this, but classically it was to write down the narrative, and then you would rewrite that over time, and then you would evaluate and think about from that narrative ideas of stuck points is the key term there. Looking through the narrative as to places that are not necessarily completely reality-based or an overgeneralization, and you would one uses Socratic questioning to kind of explore that. I'll tell you, it's hard to, while I'm doing this, write and think and kind of see it on a screen. It's just a challenging thing to do. So what you're trying to do is help people move into a more nuanced position. So let me just give an example. Let's say somebody held a priori idea that all places are good, and then they end up being mugged at some point in their life at gunpoint, and it was a really distressing situation. And then they go from that position, that a priori idea of all places are good, to an over-accommodated idea. So you exist in this world that you have assimilated, okay? This is your a priori state. And then you go to an over-accommodation of moving from the world is safe to no place is safe. And then you write down your narrative and you kind of Socratically question some ideas that come up, that hoping that you then move to a middle ground or an accommodated place where it's a more nuanced idea that some places are unsafe at certain times, as opposed to the over-accommodated idea, if that makes sense. One thing I like to kind of show from this particular brand of therapy is I find this to be really kind of neat. So the other thing you'll do is, in terms of teaching nuance, is kind of think about the ideas of trust, power, love, relationships, and there's some others, I can't remember them, but I'll quickly just talk about trust. So often folks will come in, and trust is a binary of distrust or like completely trust. And people exist in this over-accommodated world of 0 or 1. And hopefully you can show folks that it's actually more nuanced than that, that you may say trust a person 25% or 75%, or you may distrust them 25%, and etc. And then it's even more nuanced than that, and that trust can get broken into various different entities, such as I'm going to trust my banker with my banking information, I'm going to trust my wife with my children, and I'm going to trust my friend with my secrets. But I often say to guys when they meet me, and I say guys because that's primarily who I deal with at the VA, when they've returned from the war, they would not want to trust me in battle because I would not be a good battle buddy. But you can trust me with kind of ideas of emotions and this kind of thing because that's my expertise. So trust being nuanced both in amounts as well as what and where you're trusting. So it's about nuance. Excuse me. The other approach, the psychological approach that I know somewhat about, is prolonged exposure. And that's broken up into two fields, and it is audio recordings of the event, and then in vivo, which means you go out and you have to do some kind of activity like say you're afraid of going to Walmart, and so you would first have to then go to Walmart, say, during the middle of the night, at midnight when no one's there. Then you would have to go at 10 a.m. with a few people there, and then ultimately, after several weeks of doing those things and doing it every day and recording kind of how you felt during it, you would then go and go to Walmart like smack dab in the middle of the busiest time, say like 5 or 6 p.m. at night, or on a weekend day, that kind of thing, and slowly exposing yourself. And then the audio is actually an audio recording of the person themselves describing whatever their criterion A event is that they've selected as their most troubling one, because some folks, and it's not uncommon that people have multiple criterion A events, and then they record that in the room and then post-processing with the therapist, and then go home and record it again, and they listen to that recording, come back, and then repeat the narrative. And the narratives change over time as nuance is added to the story. Excuse me. So what's the goal of prolonged exposure? So it's a behavioral therapy. So instead of a cognitive therapy where you're trying to change the thoughts around it, you're trying to change the behaviors, and primarily moving towards desensitization. And the idea being that this is some negative feeling, and this is time moving in that direction. That any negative feeling somebody has, you kind of go along with that negative feeling, and then you hit some environmental cue, or the word often used as trigger. Your negative emotion goes up, and what folks often do is try to leave the situation and then, whew, survived. Or you can also do other coping strategies, maladaptive maybe coping strategies, to try to get out of the negative feeling, and then it just flattens, and then your world becomes smaller and smaller as more and more things cause this negative emotion, and the negative emotion actually will start to go up at a steeper rate and more quickly as soon as a cue comes. So you're asking people to stay with the negative emotion, so you push them to go to Walmart or listen to the story, and then they ride the wave, and then eventually it will fall. And usually that takes on the order of 45 minutes to 60 minutes. And while they're doing this, you want them to record on a scale of 0 to 100 with nuanced numbers. Where do they feel like their level of negative emotion is, or anxiety, as they go across time points here. And then with time and exposures repeatedly, this curve starts to come down, and then hopefully you'll still have, you can never get rid of all negative emotion. Negative emotion is actually beneficial. We want to be afraid when we go across the street and we see a car coming, that we shouldn't do that, but that you resensitize yourself so the things that should be frightening, like being in a dark, perhaps dangerous part of a city, you should have your guard up, but being in a well-lit, middle-of-the-day grocery store, you can let it down. So you resensitize so that your anxiety levels are specific to where you're at. So desensitization. So that is the mainstay of treatment. And we've talked about treatment. We've talked about the symptoms. And the last thing I want to talk about is arenas of trauma. And then I work at a Veterans Administration, as I mentioned. So I know a little bit more about the male kind of arena of trauma. What I should say is classical male. So I don't mean to exclude any person, any female who has experienced war or political violence as the means of their trauma. And I don't mean to exclude any male that has experienced rape or domestic violence as their trauma. But the kind of trauma and recovery kind of divides it into these worlds. A classic book by Dr. Herman, who talks on trauma. It's an excellent book if you get a chance to read it. So that's Trauma and Recovery, that the domains of men are war and political violence, and the domains of women are rape and domestic violence. And that's not to exclude those that do not fit those criteria, but just as a characterization schema. And then in the work that I do, I think about veterans, and I kind of divide it into like, what's the difference between World War II, Vietnam, and then post-Vietnam, and then more specifically global war on terror. Now, the ones I know something about are World War II, Vietnam, and then the global war on terror. And there aren't that many World War II veterans. In terms of the actual number of veterans, in total, there are about 20.4 million veterans in the United States today of all wars. There's still about 500,000 World War II veterans, 1.3 million Korea veterans, 6.5 million Vietnam veterans, and then Desert Storm on 7.4 million, and of that cohort, about 3.5 million are post 9/11. And GWOT stands for Global War on Terror, and that includes Operation Iraqi Freedom, Operation New Dawn, and Operation Enduring Freedom, and then the additional ongoing conflicts that we're engaged in today. So if you were to think about how these guys entered into combat together, when they were there in World War II, folks went in kind of as units and stayed together throughout the time that they were there. And you've maybe seen a movie like Band of Brothers, which is very different, say, than in Vietnam, where they went in for 11 to 15 months, and they would go in often as kind of replacements. So I'll continue to kind of compare World War II and Vietnam, which I think are very different kind of conflicts. So the number of days when a person was actually in hand-to-hand combat in World War II, and these numbers are from memory from the Ken Burns documentary on Vietnam. So if you're interested, please go and watch that movie, which I think is really excellent. But in terms of straight hand-to-hand kind of fighting, or direct fighting, I shouldn't say hand-to-hand, but direct fighting was about 45 days when somebody was in World War II. Whereas if you were in Vietnam, it was on the order of like 270 days. So kind of a significant difference in 1 year of fighting. The reception when folks came home, they were heroes, and here they came back to a divided country, and they were not always welcome. With really sometimes difficult names and epithets being thrown at them. The current age of World War II veterans are in their 90s and above. Vietnam, 60s plus, and then Global War on Terror guys in Desert Storm, kind of 50s-ish, and then here we have kind of 20s into their 40s. So here I wrote number of veterans alive, and I had already talked about that up here. What I would like to talk about, though, is kind of what was the mission? How did they accomplish their mission? This World War II, they took over cities, right? So they took capitals, and they took geography. And so they took Rome, Paris, Berlin in the European theater, and then Tokyo in the Pacific theater. In Vietnam, the mission was body count, and they were fighting an ideology, which was pretty tough to do, and hard to ever come to some kind of resolution. In terms of our current conflict, I would say it is also capitals and then it shifted. And why I have made kind of a slight change in the 2 here is that 01 to approximately 09, that was kind of our shock and awe, and that would be like taking over areas. And then 09 to present, we shifted to nation building, which is a bit of a different task to ask a human being to do. So just to think about, you know, the person that one meets that has in the United States been a participant in a conflict would be a very different experience from World War II to Vietnam to the global war on terror. And I'm not trying to create some generalized identity that can stand for talking to the person in front of you, but it's just to think about how different these experiences were. And also I wanted to draw attention to this line that I've made right here. And what's really different between these areas to the left of that line and the areas to the right of that line are the draft occurred here. And folks often did not choose to engage in those conflicts, which is a different thing than being part of a volunteer army, or military, I shouldn't just say army, military. So those is, again, kind of, we reviewed the ideas of what is PTSD, where did it originally originate, out of an idea of maybe moral injury, what were the criteria, how does one treat it pharmacologically and psychologically, what are the classic arenas of trauma as defined by Dr. Herman, and then what are the differences in the different conflicts the United States has been involved in. Again, my name is Jim Leffler. Hope you enjoyed this. Please leave comments below to help me make better videos, and feel free to hit the like button. And once again, these are my clinical ideas and approaches and are not reflective of the Veterans Administration or any of the other entities for which I work. Thank you so much.